So, Bismillahirrahmanirrahim. Assalamu alaikum, everyone. So, my dear student, we will continue the revision of a chapter of a Neoplasia. Okay. So, till now, beta, we are able to know about the difference between the benign and the malignant tumor. Okay. And it is frequently asked in your viva about the features of a malignant tumor, about the features of the benign tumor, what are the fundamental changes seen in a cell which causes the formation of a malignant cells? Okay, we discussed it in detail. And yesterday we discussed about the genetic changes in a cell which causes the formation of a tumor. And we discussed about the four classes of a gene like the activation of the proto-oncogene, and there is an inactivation of the tumor suppressor gene and the gene that controls the apoptosis, as well as the gene that is involved in DNA repairing. Clear? So, beta, we will continue the revision of this topic. So basically, beta, today we will discuss about the genomic instability and beta, genomic aberration that increase the mutation rate are very common in cancers. Okay, so there is a genomic instability is seen, and there is expected rate of the sorry. So causes the driver mutations that are required for the transformation and subsequent tumor formation. Okay, yesterday we discussed that the driver mutation is basically a mutation that is responsible for the initiation of the event of a towards the malignancy. So inherited disorder leading to the malignancy. As for example, we will discuss one by one, like hereditary non-polyposis colon cancer syndrome. So this tumor is responsible for an abnormal copy of a mismatched repair gene. Okay, like MLH1, MSH2, MSH6. These people are at increased risk of developing cancers of the cecum and proximal colon. And the patient with hereditary non-polyposis colorectal carcinoma show a microsatellite instability. Okay, beta, the patient shows a MSI instability and is characterized by changes in the length of the short repeats throughout the genome. So this is an example of a genomic instability. Okay, means the malignancy can occur due to the genomic instability, and the example is like a hereditary non-polyposis colorectal carcinoma. Clear? I repeat it again. In hereditary non-polyposis colorectal carcinoma, there is a microsatellite instability. Okay. The other example is xeroderma pigmentosa. In a xeroderma pigmentosa, the patient have an inherited disorder of a DNA repair gene. DNA repair gene के अंदर alteration is responsible for the xeroderma pigmentosa, and it is responsible for the skin carcinomas. Okay, particularly exposure to the ultraviolet radiation in sun rays. Clear? So the syndromes involving the defect in the homologous recombination of a DNA repair system constitute a group of a disorder which we call a Bloom syndrome, ataxia, telangiectasia, or and a Fanconi's anemia. Clear? These type of a disease associated with a defect in the DNA repair system. Clear? So, beta, it is characterized by a hypersensitivity to a DNA damage agent like ionizing radiation, BRCA1, BRCA2 are involved in a DNA repair. Clear? So mutation increase in lymphoid cells due to expression of a gene product that induce the genomic instability, an important cause of a lymphoid neoplasm. Now the chromosomal changes. Okay, the dysregulation in a chromosomes. So chromosomal changes in certain chromosomal abnormalities are highly associated with particular neoplasm. Clear? Till now, we are able to know that the tumor can be occurred due to the activation of the oncogenes. There is a mutation of a gene like oncogene. Okay, then we discussed different type of mutation, different type of genes that play a role in a tumor suppressor gene. And now we are discussing about the chromosomal changes. Okay, So certain chromosomal abnormalities are highly associated with a particular neoplasm and lead to the dysregulation of a gene with an integral role in the pathogenesis of that tumor type. The chromosomal rearrangement like translocation, inversion, amplification, small deletion can activate the proto-oncogene or loss of a function of a tumor suppressor gene. So the chromosomal translocation is basically a translocation can activate a proto-oncogenes in two ways: by promoter or enhancer substitution, in which the translocation enhances proto-oncogene by swapping its regulatory elements with those of another gene, typically one that is highly expressed. By formation of a fusion gene in which the coding sequence of two genes are fused in parts or in whole, leading to the expression of a novel protein with oncogenic properties. Clear? This is an example of a chromosome translocation. Overexpression of a proto-oncogene beta caused by a translocation is seen in a Burkitt lymphoma. The example of a translocation is Burkitt lymphoma. It is given in your book Robbins in the chapter of Neoplasia that the chromosomal translocation is seen in Burkitt lymphoma. And the translocation is seen in chromosome 8 to 24 where the MYC gene resides. Okay? So in Burkitt lymphoma, there is a role of a MYC gene. And and there is a mutation in the 9 and 22 is seen in case of a CML. Chronic myeloid leukemia, there is a translocation between the chromosome 9 and chromosome 22. There is a BCR-ABL fusion. Okay. So now the other example, the dysregulation of the cancer-associated genes includes the chromosomal deletion. So basically, beta, the deletion of a specific region of a chromosome is associated with the loss of a particular tumor suppressor gene. Here, as I already discussed that the tumor suppressor genes are responsible to suppress the tumor. Whenever there is a loss of a function of a tumor suppressor gene, then there is a development of a malignancy. Okay, so deletion involving in chromosome 13 to 14 at the site of retinoblastoma gene, as we discussed yesterday, that the RB genes is an example of a tumor suppressor gene. Okay, so this deletion in chromosome 13 at the site of retinoblastoma gene are associated with the development of a retinoblastoma. Clear? Other example is deletion of a von Hippel-Lindau gene, VHL gene on chromosome 3p is seen in beta renal cell carcinoma. Here, not all deletion lead to loss of a gene function. A few deletions also activates the oncogene. Clear? Beta, today we are discussing about the role of a chromosomes, and we discussed that there may be a chromosomal translocation. The example is Burkitt lymphoma and the CML, chronic myeloid leukemia. Okay. Then we discussed about the chromosomal deletion. Behind the chromosomal deletion, the example is an example of deletion in 113q in case of a retinoblastoma and the chromosome 3p in case of a renal cell carcinoma in a gene VHL. Clear? So now the amplification. Overexpression of an oncogene may also result from reduplication and amplification of their DNA sequences. Amplification may produce several hundred copies of oncogene in tumor cells. Microscopically, two patterns are seen: the double minutes and the homogeneous staining region. Now, because we will discuss about the clinical aspect of the neoplasia. Okay, means what are the effects of the neoplasia? Clear? So there may be the local or a hormonal effect. Location beta is a critical determinant of the clinical effect of both benign and the malignant tumor. Okay, हम ये नहीं कह सकते कि benign tumor हमेशा ऐसा करेगा, हम ये नहीं कह सकते कि malignant tumor हमेशा ऐसा करेगा. It depends upon the location. As for example, beta, the pituitary adenoma, as the name indicates, OMA, it is basically a benign tumor. Pituitary adenoma is a small 1 centimeter non-functional which can compress and destroy the surrounding gland and can lead to the serious hypopituitarism. Although it is a benign, but it can cause the serious hypopituitarism because it depends upon the location. Neoplasm in the gut, both benign and malignant, can lead to the obstruction as they become enlarged. Yeah. So in the brain, tumors are space occupying region and even the benign tumor can destroy the surrounding normal brain tissue because of pressure. Clear? So benign and malignant tumors arising in the endocrine glands can cause the clinical problem. A benign beta cell adenoma of the pancreas less than 1 centimeter can produce a sufficient insulin to cause a fatal hypoglycemia. Clear? So beta, keep it in your mind that the features of benign and malignant tumor is also depend upon the location. Sometimes if a tumor is benign but it is present in a certain location like in a brain, like in a pituitary gland, so it may causes the pressure effect, it may causes the serious type of symptoms. There. So now we will continue the discussion of clinical aspect of the neoplasia. The, the cancer patient may present with a feature of a cancer cachexia, in which the individual suffering from cancer progressively lose the body fat and lean body mass because there is a profound weakness, anorexia, and anemia. There, so it is associated with equal loss of both fat and lean muscles, elevated BMR, evidence of systemic inflammation. And why these features are occurred? Because the mechanisms that underlying are not understood, but there is a role of a tumor necrotic factor. These tumor necrotic factor beta basically is responsible for the loss of a appetite. So, humoral factors release from a tumor cells such as proteolysis inducing factors have been implicated in the loss of a muscle mass. Now the paraneoplastic syndrome. Because this question is very important. It is frequently asked that in your viva about the paraneoplastic syndrome. Anyone can ask what is paraneoplastic syndrome, gives the examples of paraneoplastic syndrome, and tell the tumor which produce these paraneoplastic syndrome. Whether this can be asked in your in your SCQ that tell the names of the tumors which play a role in a paraneoplastic syndrome. So basically, because some individuals with cancers develop signs and symptoms that cannot be readily explained by the anatomical distribution of the tumor. मतलब ट्यूमर जहाँ का है तो इस तरह के साइन एंड सिम्टम्स देगा जो कि उस जगह के नहीं लगेंगे. So some individual with cancers develop signs and symptoms that cannot be readily explained by the anatomical distribution of the tumor or by the elaboration of a hard wound to the tissue from which the tumor arose. These are known as paraneoplastic syndrome. These are seen in 10% of cases. So, the paraneoplastic syndrome are important to recognize. They may be the earliest manifestation of an occult tumor. In affected patients, they can cause a significant clinical problem and may be lethal. They may mimic a metastatic disease and need a treatment. So now the examples are the paraneoplastic syndromes may show endocrinopathies. Okay, they show endocrinal features. So endocrinopathies are frequently seen in a paraneoplastic syndrome. The responsible cancers of not of endocrine region and secretory activity of the tumor is referred to as a ectopic hormone production. Cushing syndrome is the most common endocrinopathy. 50% of the cases with this syndrome have a small cell carcinoma of the lung. Okay, so means as we know that the Cushing syndrome is basically ideally the Cushing syndrome is basically an increased ACTH level, increased cortisol level. So, but in certain tumors like in a small small cell carcinoma of the lung, the patient may present with a Cushing syndrome. And this is due to the production of ACTH-like substance from a small cell carcinoma of the lung. So this is an example of a paraneoplastic syndrome. And it is caused by excessive production of a corticotropin. Precursor is opiomelanocortin, which is seen in a patient with a carcinoma and not found normally in the serum. Clear? So, beta. Now the hypercalcemia. Beta hypercalcemia is caused by osteolytic induced by cancers, both by primary and metastatic bone tumor. But it is not considered as paraneoplastic. Clear? Production of a calcemic humoral substance by extraosseous neoplasia. Clear? So this is an example of a paraneoplastic syndrome. Now, several other factors are associated with a paraneoplastic hypercalcemia of malignancy. The parathyroid hormone-related protein is produced in a small amount of normal tissue, keratinocytes, muscles, bone, and organs. Tumor most often associated with hypercalcemia are, because this can be asked in your SQ, that give the example of a tumor which are associated with hypercalcemia. So these tumors are carcinoma of the breast, lung, especially the squamous cell carcinoma, kidney, and ovary. Other factors are interleukin-1, transforming growth factor, tumor necrotic factors, and dihydroxy vitamin D are implicated in the hypercalcemia. So neuromyopathic paraneoplastic syndrome. Now, so beta, till now we are able to know that paraneoplastic syndrome is basically a syndrome which shows features that is not according to the anatomical equivocation of the tumor. Okay, the best example is Cushing syndrome from a small cell carcinoma of the lung. Then we will discuss about the hypercalcemia. Now, the neuromyopathic paraneoplastic syndrome takes diverse forms such as peripheral neuropathy, cortical cerebellar degeneration, polymyositis, and myasthenia gravis. Antibodies produced against cancer cell antigen may cross-react with the neuronal cell antigens. So, now the acanthosis nigricans, these all are example of the paraneoplastic syndrome, Cushing syndrome, hypercalcemia, and then neuromyopathic paraneoplastic syndrome, then parathyroid related protein. Okay, so now about acanthosis nigricans. It is basically a disorder characterized by a gray black patches of a thickened hyperkeratotic skin with a wormity appearance. Clear? So hypertrophic osteoarthropathy is seen in 1 to 10% of the patient with lung carcinoma. ठीक है बेटा, the example of hypertrophic osteoarthropathy is lung carcinoma that is characterized by a periosteal new bone formation in the distal ends of metatarsal, metacarpus, and proximal phalanges, arthritis, and the clubbing of the digits. Okay, clear? And the other examples include vascular and hematological manifestation, very, very important. The migratory thrombophlebitis or atrocious sign can be seen in case of a CA pancreas. Intravascular coagulation, or we call a DIC, can be seen in case of a prostatic adenocarcinomas, and a small vegetation on the heart valve are seen in a creating adenocarcinoma. Clear? So now again the carcinoid syndrome. Beta carcinoid syndrome is a paraneoplastic syndrome that comprising the signs and symptoms that occur secondary to the carcinoid tumor. The syndromes include flushing and diarrhea less frequently, heart failure, vomiting, and bronchoconstriction. It is caused by an endogenous secretion of mainly serotonin and calcium. So, beta, this is a chart. If anyone asks in your SQ, then you may make this type of a chart. That the example of a paraneoplastic syndrome is is the nerves and muscle syndromes, the metallurgical disorder, osseous, articular, and soft tissue changes, vascular and immunological changes, and others. Clear? So, in a nerve and muscle syndrome, there may be the myasthenia gravis, there may be a central and peripheral nervous system disorder, and this is associated with the bronchogenic carcinoma, and the central nervous system and peripheral nervous system is associated with the breast carcinomas. Okay, while in a dermatological disorder, acanthosis nigricans is caused by a gastric carcinomas, the lung carcinomas, the uterine carcinoma here, and the dermatomyositis is caused by a bronchogenic breast carcinomas here. So basically, beta, the other example is osseous. There is a hypertrophic osteoarthropathy and clubbing of the fingers. It is caused by a bronchogenic carcinoma. Okay, you must prepare this chart for your SEQ. Now the vascular neurological changes including the venous thrombosis, uh, which is caused by pancreatic carcinoma, bronchogenic carcinoma, non-bacterial thrombotic endocarditis is caused by advanced cancer, red cell anesthesia is caused by a thymic neoplasm. Clear? And the nephrotic syndrome is caused by a various cancers. Okay? So, uh, this is a clinical syndrome in endocrinopathy. It may cause Cushing syndrome, it may cause the syndrome of inappropriate antidiuretic hormone. But this chart is very, very important. Okay, then you must know that the Cushing syndrome is caused by small cell carcinoma, pancreatic carcinoma, and bone tissue, and this is due to the production of ECDS-like substance. Clear? And the syndrome of inappropriate antidiuretic hormone secretion is caused by small cell carcinoma. Okay, and it is due to the production of it antidiuretic hormone. Okay, then the hypercalcemia. Hypercalcemia is basically caused by squamous cell carcinoma, breast carcinoma, renal carcinoma, and adult T-cell leukemia, and it is due to the parathyroid hormone related protein. Now, the hypoglycemia is caused by ovarian carcinoma, fibrosarcoma, and other mesenchymal and it is due to insulin or insulin-like substance. Now, the carcinoid syndrome. The carcinoid syndrome is caused by hepatocellular carcinoma, the bronchiolatinoma, pancreatic carcinoma. Okay, and then there is a polycythemia. Polycythemia is occurred due to the production of erythropoietin, and the best example is the renal cell carcinoma, gastric carcinoma, HCC, hepatocellular carcinoma, and the cellular angioma. Better this chart is also in your book, Robin. So you must prepare this topic. I'm telling you again and again, beta paraneoplastic syndrome is always asked in your viva. Okay, most of the examiners are found to ask about the questions of paraneoplastic syndrome. Okay, you must know what is paraneoplastic syndrome, and you must know about the examples along with the tumor. Okay, like Cushing syndrome is caused by a small cell carcinoma because of ACTH-like substance, etc. Clear? So now we are starting a new topic that is reading and staging. Okay, till now we are able to know about the genetic changes. Till now we are able to know about the genetic changes in cell which causes the production of a malignant cell. There may be a role of chromosome, either in the form of chromosome amplification, and a chromosome deletion. There, and we are also know that there is a main role of a gene, proto-oncogene, and then there is a tumor suppressor gene and the gene that controls the apoptosis and the repair gene. Clear? So now we are starting with our new topic that is grading and staging of the tumors. Clear? So beta, what is grading? What is the importance of grading? So basically, beta, grading of a cancer is based on a degree of differentiation of the tumor cells, number of a mitosis, and architectural features. Grading depends on psychological appearance of tumor. The tumors can vary from well-differentiated tumors moderately differentiated to poorly differentiated tumor. The well-differentiated have better prognosis than moderately and poorly differentiated. In sarcomas, the number of mitosis per high power field are important as well. There, beta grading is basically is dependent upon the differentiation, mitosis, and the architectural feature. Okay, if anyone asks what are the features which impact on the grading, so it is basically a differentiation of the tumor cell, number of mitosis, and architectural features. Okay, the tumor can vary from well differentiated to moderately to poorly differentiated. This is a grade. Like we grade squamous cell carcinoma into three grades: the well differentiated squamous cell carcinoma, the moderately differentiated squamous cell carcinoma, and the poorly differentiated squamous cell carcinoma. As for example, the well differentiated squamous cell carcinoma shows a good prognosis, and it looks like a it looks like a normal squamous cell with atypia and mitosis. While a poorly differentiated is a poorly differentiated shows a poor prognosis, and uh, it is not identical with their benign squamous epithelium. Okay, so now the staging. With the staging of a solid cancer is based on the size of the primary lesion, extent of the spread of the regional lymph nodes, presence or absence of a blood-borne metastasis. Okay, so TNM classification of staging. T is for primary tumor. Okay, so बेटा हमने क्या डिस्कस किया अभी तक? रीडिंग हमें समझ आ गई कि डिफरेंशिएशन पर है, स्टेजिंग जो है वो डिपेंड करती है size of the lymph node. ठीक है, हमारी T and M. T is for tumor size, N is for lymph node, and M is for metastasis. Okay, so staging is dependent upon these three features. Okay, and is based on the size of the primary lesion. So the TNM is classification of the staging of the T. T is for primary tumor, N is regional lymph node, and M is for metastasis. The primary tumor beta is based from T1 to T4 depending on the size of the tumor. And node is basically a no nodal involvement, and 1 to N3 is basically an involvement of increasing number of a lymph node. And M node is basically a no metastasis. M1 is associated with metastasis. Yeah. So beta, I'm telling you again that staging is dependent upon the tumor T and N. If we discuss the T, T is basically the size of the tumor. If the size is increasing according to the different tumors have different criteria according to the size, we classify the tumor into T1, T2, T3, and T4. Okay. In N, the nodal metastasis play a role. If there is no nodal metastasis, we call it N not. If there is a nodal metastasis, then we call it N1. It depends upon the number of lymph nodes involved. So it may be classified to N1, N2, N3. And in beta M0, there is a no metastasis. In M1 and M2, there is a metastasis. Clear? So now, ये देखेंगे कि खत्म होने वाला है इसका है, अगर इसको बंद करके दोबारा चलाने के लिए रुक जाए, ये आया मतलब okay beta. So beta, now the laboratory diagnosis of the cancer. Okay. Beta, sorry, I didn't mean staging and grading of the tumor can be asked in your viva. Okay, so I hope you can understand the concept of the grading and staging. Okay, so grading is basically dependent upon the differentiation, and the staging is dependent upon the T. Okay, so the important topic of Neoplasia chapter is Paraneoplastic Syndrome. You must know about tumor and staging and grading, and then you must know about the features of benign malignant tumor, Beta, you must know about the genetic changes, the role of the gene, the four classes of the gene. You must know about the eight fundamental features of the malignant cells, like angiogenesis, like self-sufficiency, like change of metabolic pathway into aerobic glycolysis, etc., etc. Clear? And the important chapter, important topic of neoplasia is basically beta nomenclature. Anyone can ask about the benign and malignant tumor nomenclature. Clear? Clear? And then it is frequently asking your Viva about the tumor that arises from the three germ cell layer, the tumor that arises from the one germ cell layer. Okay, so and the other important topics are the role of a proto-oncogene, the example of the oncogene, the example of a tumor suppressor gene. Okay, and then there is a role of a rest mutation, clear, and then there is a certain there is a role of rest mutation, there is a role of a tumor suppression, there is a role of a chromosomes, example of a chromosome translocation, example of a chromosome amplification, and example of a chromosome deletion. Okay, these all play a role for the development of a malignant cell. This is all about the chapter of neoplasia. Then we will discuss about the lab diagnosis of the cancer. There is a role of certain enzymes, certain role of certain enzymes which help in the detection of the cancer. And now we will